My name is Ashley Sullivan. I am the Mohs surgeon at Dermatology Associates of Virginia. So Mohs micrographic surgery initially got created in the 1930s by Frederick Mohs in Madison, Wisconsin at University of Wisconsin. And it didn't really get revolutionized until a couple decades ago, where University of California re-looked at it, how they could improve the methodology and make it more applicable. But we named the procedure micrographic surgery after Frederick Mohs in honor of how large of a contribution this was to skin cancer treatment. He actually wasn't a dermatologist, he was a general surgeon. Now he has a legacy of thousands of Mohs surgeons who practice what he does and give results that allow tissue sparing and allow the highest cure rate than anything else out there. Since then, it's become the gold standard of skin cancer treatment for a majority of the most common skin cancers. So basal cells and squamous cells end up being a bulk of my patients. Essentially, patients come to the Mohs surgery center either very early in the morning or at lunchtime, because chances are you're going to be with them for at least half a day. And so each patient gets individually brought back to a room. There we talk about their skin cancer diagnosis. After everyone asks their questions and goes through the treatment options, they then sign their consent form and say, nope, I've heard all the options, I'm agreeable to the surgery. After that, we numb them up, which probably takes a good 5 minutes or so, and then we take the layer of tissue. That in general takes 5 to 10 minutes. And then they get brought back to the waiting room, and they wait for about an hour and a half for the slides to be processed. After that hour and a half wait, I read the slides. To be a Mohs surgeon, you have to be the surgeon and the pathologist, and that's what makes me different than my colleagues in plastic surgery and surgical oncology, is I actually read the slides. So I read the slides, and then I make a determination. If the skin cancer is out, then we stitch the patient. If the skin cancer is not out, I take more tissue only in the direction that it's positive. And that's how, in the end, Mohs ends up having the highest cure rate, and it cuts the least amount of tissue, is because you're not taking a whole entire circle every time you have to take more tissue. Sometimes you only have to take more tissue in a very small percent. So every patient heals differently, and everyone's scar heals at a different rate. So we don't show patients pictures here, but we like to draw on purple. So I have a purple surgical marker, and we love to draw on folks to kind of get them on the same page of us of what we anticipate your scar is going to look like.